afternoon, everyone. This is
Microphone.
okay. Good afternoon, everyone. This is session 5 for this first day. The topic is chronic liver diseases. In this session, we will talk about autoimmune and cholestatic liver disease, non-invasive assessment of cirrhosis and portal hypertension, TLM debrief, and lastly, 2 case-based panel discussion. The first talk is coming from Dr. Cynthia Levy. I will talk about Dr. Levy for a few moments. She is a professor of medicine in University of Miami Miller School of Medicine and also associate director of Schiff Center for Liver Diseases and the program director of Transplant Hepatology Fellowship at the same university. She is graduated from medical school at Universidade Federal do Rio de Janeiro. She completed residency in internal medicine at University of Miami-Jackson Memorial Hospital, gastroenterology at Mayo Clinic, Rochester, and transplant hepatology at University of Florida, Gainesville. In 2010, she returned to the University of Miami as an associated professor. At that time, I was in Miami University as an observership program for liver transplantation. As you all know, her main research interest is autoimmune and cholestatic liver disease. It's an honor for me to invite Dr. Cynthia Levy. Please leave.
Well, thank you for this nice introduction. It's my pleasure to join you all here today and present some of the work that was discussed at the liver meeting. All right, let's get started. These are my disclosures. Okay, so this is how I divided the presentation. I'm going to start with primary biliary cholangitis, then primary sclerosing cholangitis, symptoms and quality of life, and we'll end with autoimmune hepatitis and IgG4 related disease. Now, another disclosure here is that there were close to 200 abstracts between posters and oral presentations in the liver meeting, and I only get to select fewer than 10% for today's presentation. More than half of the abstracts were on PBC, so we're going to start with that. So, alkaline phosphatase and bilirubin have been used as prognostic markers in patients with PBC treated with UDCA for decades, and they were the base of approval for 2 new therapies in 2024, elafibranor and seladelpar. What we don't know is if these biomarkers remain of prognostic significance once patients are on second-line therapy. So this was a very nice real-world study by the Global PBC Study Group. That's an international registry. And they selected about 860 patients who had been on second-line therapy. Half of those were on OCA, obeticholic acid, another half on fibrates. About 20% of this cohort was was cirrhotic. And as you can expect, at baseline, alkaline phosphatase was close to 2 times the upper limit of normal. After a year of therapy, it dropped to 1.3 times the upper limit of normal. What was key in this study is the graph on your right side, where patients who dropped their alkaline phosphatase to below 1.67 times the upper limit of normal, and this is the Toronto criteria, these patients had about 45% reduction in the risk of death or transplant. And not shown here, but those who met the POISE criteria, that's decreasing alk phos to below 1.67 times the upper limit of normal with a greater than 15% reduction from baseline and maintaining normal bilirubin, had a 66% reduction in the hazards of death or transplant. Along the same lines, this is a study from the Netherlands where the investigators looked at their patients with PBC and incomplete response to also consecutive patients who were treated with bezafibrate. And on this graph here, you can see, so figure 1, you can see that regardless of which response criteria you're looking at, 60 to 70% of patients met POISE or Toronto criteria after a year of therapy. Now, if you look on the last graph, this is the age-adjusted hazard for liver decompensation, liver transplantation, or death while patients were on fibrate. And this is age-adjusted. And you can see with higher alkaline phosphatases, while on treatment with fibrates, you have higher hazards of liver events, death or transplant. There is a separate graph not shown here that's adjusted for cirrhosis, and it remains significant. So alk-phos is a good predictor even if you're on second-line therapies. Now, knowing what we know now, what second-line therapies can do for patients with PBC and incomplete response to URSO, this study was a bit of a shocker. There were several abstracts on guideline implementation in the liver meeting. I selected this one because it came from Latin America, and we didn't have data until then from that continent, from South America. So they have the Latin cohort, about 1,200 patients with PBC, about 1,000 were on ursodiol, and as expected, after a year of therapy, roughly 39% had incomplete response. But only 30 to 40% of these patients were offered second-line therapy, despite the fact that bezafibrate is cheap and readily available there. So it's a huge unmet need for us. Now, moving to the therapies that are approved, we have known, so elafibranor was the first one approved based on the ELATIVE trial. And in the liver meeting, we presented long-term data, so 3 years of follow-up on patients on elafibranor. You can see, do you see my arrow? No. You can see at 52 weeks, 56% of patients had met the response criteria, and at 3 years, the proportion of patients with biochemical response was sustained at about 70%, despite the fact that 40% of the patients had quite elevated alkaline phosphatase at baseline, more than 3 times elevation. The other graph shows that liver stiffness remained stable for the 3 years, despite the fact that at baseline, the average LSM was 10 kilopascals. Okay? And the bottom 2 graphs show improvement in symptom scores. So on the left, you have the fatigue promise score. On the right, you have a pruritus NRS score for patients who had moderate to severe fatigue or pruritus. And you can see significant declines over time. Similarly, we had data from Celadopar in their open-label follow-up study called ASSURE. Here we had 3 years of data for biochemical or efficacy data and 4 years for safety data. And again, similar to what we see with elafibranor, the response is sustained. We have that significant drop in alkaline phosphatase that we see in the first month of therapy is also sustained for the duration of treatment. 33% of patients with normalization of alkaline phosphatase, another 33% almost with normalization of alk-phos and bilirubin, and that without any new safety signal. Another interesting paper on Celadopar was this one, looking at liver stiffness. This is en vogue. So this is a subset of the patients in the ASSURE trial who had at least one more liver stiffness measurement after the baseline one. There were 114 patients, and 85% of them maintained or had a significant decline of 30% or more in liver stiffness.
You can use spot.
Yeah, thank you. Got it. And only 17 of the 114 patients had worsening of 30% or more in liver stiffness. And those patients who had worsening tend to be younger or have higher alkaline phosphatase at entry. But the vast majority, 85%, remained stable or improved. Well, this is a network meta-analysis. It's a way for us to evaluate and compare the effectiveness of these drugs, even though the trials were not head-to-head. And basically what this is showing is that they had comparative efficacy. So we cannot say, based on our network meta-analysis, that one drug is better than the other. Our patients have multiple options. Let's go to primary sclerosing cholangitis. Elafibranor was studied in the ELMWOOD trial. This was a phase 2 randomized controlled trial that we presented in EASL last year. 12-week randomized, 67 patients were randomized to placebo versus 80 milligrams or 120 milligrams of elafibranor. This is the long-term extension. This was presented in the liver meeting. And you can see in this graph here, 12 weeks is the end of the double blind. You see the dose-dependent response in alkaline phosphatase. At 12 weeks, patients on placebo and those on the 80 milligrams were converted to 120 milligrams, and you can see the 40% reduction in alkaline phosphatase for the previously placebo-treated patients. ELF remained stable throughout the 6 months of treatment, although if you focus on the far right on patients who had high ELF at entry, greater than 9.8, those patients seem to be declining the ELF, and the improvement in pruritus was also sustained for the duration of this open label extension. Talking about newer therapies, nebokitug. I don't know if you heard about nebokitug. This is a monoclonal antibody against CCL24, and CCL24 is a cytokine involved in inflammation and fibrosis. So the SPRING trial was a proof of concept 15-week study that had been presented in EASL and showed stability of the markers of fibrosis. In the liver meeting, they presented the open label extension of the SPRING trial. And what they showed, let's focus here on the bottom graphs. So those are the patients who started out with moderate to advanced fibrosis, and that's based on ELF. And you can see, oh my God, sorry, a decrease in ELF as well as some of its components, especially with the higher dose of 20 milligrams per kilo comparing to the low dose of 10, and improvement in ProC3, which is another non-invasive marker of fibrosis. So promising therapies. And the way CCL24 does that is by modulating macrophage stimulating factor 1, which is usually lower, not very well expressed in patients with PSC. So with this treatment, we can restore the macrophage stimulating factor 1. All right, more on liver stiffness. We heard a lot about liver stiffness measurements in MASLD, and that's because that's a very common disease, and there are plenty of studies out there. But we don't have enough data for cholestatic diseases, especially PSC. So this study was pretty remarkable. I know this is a busy slide. This came from Toronto. The derivation cohort had 400 patients, and they validated their results on 3 independent international cohorts. One from North America, one from Hamburg, and another one in Canada. And the message here is this. This is log transformation of liver stiffness, and it is associated closely with the hazard ratio of liver events. And here it were hepatic decompensation events, death, or transplant. So showing that, yes, we can use liver stiffness as a good way to track patients with PSC prognostically. We use these different cutoffs for this study because that's the original study from Christophe Coprechot in France, but I can tell you that we did additional analysis with the Baveno cutoffs, and it all remains significant. Let's now talk about symptoms and quality of life, because that's one of the pillars for treatment of cholestatic diseases. We want to prevent disease progression, and we want to manage symptoms and improve quality of life. We heard previously about the biochemical response that we have with seladelpar and elafibranor, and how that can impact on progression of disease. So now I'm showing you the impact on symptoms, specifically with seladelpar, and this is data from the ASSURE trial. What we're showing here, so patients were stratified according to the severity of the pruritus entry. NRS is a scale that goes from 0 to 10. If you have 4 or more, that's considered moderate to severe pruritus. This was a key secondary endpoint for the seladelpar trial, and it was met in the RESPONSE trial, the phase 3 trial. This is the open label. So up until 12 months, we have the dark blue bars are patients on seladelpar 10 milligrams. The gray bars are the placebo patients. And look how nicely after month 12, the orange bars are the patients who converted from placebo to seladelpar 10 milligrams. And we can see this nice slope of response appearing there in patients who were previously treated with placebo. And this response, this improvement in pruritus, and here we're talking about a greater than 3 or more points reduction in the NRS, and this is clinically significant, not just statistically significant, and this is sustained for the duration of the study. We also looked at changes, not only changes in the NRS, but changes in the 5D itch, which is a multidimensional survey that we use to assess pruritus, and the PBC-40 each domain. PBC-40 is a quality of life questionnaire that is specific for PBC and has a specific each domain. So it doesn't matter how you look at it, there's significant improvement once patients cross over from the placebo to seladelpar 10 milligrams. How about with elafibranor? What they showed in this study was, yes, there were changes in fatigue and in pruritus scores for patients who started out with moderate to severe symptoms, and I showed that in the other slide. But here, the key of this analysis is that they tried to look at correlations between the improvement in symptoms and the improvement in the biochemistries driven by elafibranor, and the correlation was very, very weak, maybe suggesting a different mechanism by which the drug may be improving symptoms, separate from the improvement in cholestasis. Now, this is a very cute study looking at diet. It's not easy to do studies looking at diets because there are so many variables and confounders. This is a small study, 48 patients with PBC who were given a survey, a questionnaire to evaluate the quality of their diets. It's called the Healthy Eating Index, the Alternative Healthy Eating Index. And what they showed was a correlation between higher quality in the diet and improvement in liver health and in symptoms. So for each 10 points in this healthy eating questionnaire, each increase in 10 points, there was a decrease in steatosis, liver stiffness, and bilirubin levels. Very mild decreases, of course, but this is only for each 10 points that it goes up. And improvements in that PBC-40 global scores that I mentioned to you. This is a quality of life survey. The better the quality of the diet, so higher vegetables, higher fruits intake, higher the polyunsaturated fatty acids, they had better liver health, okay, and including decreased progression to cirrhosis in the higher POFA group and decreased symptoms. So it's something that you can share with your patients to change the day-to-day management beyond medications. Okay, finally, let's talk about autoimmune hepatitis and IgG4-related disease. It's about time for us to investigate new therapeutic options in autoimmune hepatitis that can allow for us to get patients off steroids or really minimize immunosuppression or steroid doses and all the side effects. Zetomipzomib is a first-in-class immunoproteasome inhibitor, and this was evaluated in a phase 2A randomized controlled trial, 24 weeks study, for patients with autoimmune hepatitis who had ongoing inflammation despite the immunosuppression, and that was biopsy proven, so they had to have a hepatic activity index of 5 or greater out of 18, 5 or more, and the ALT had to be elevated more than 1.25 times the upper limit of normal. This drug suppresses B cells and increases regulatory T cells. And what you see the patients were randomized on a 2-to-1 fashion, and what you see is the rate of complete biochemical response was 2 times more common in patients treated with Zeto as opposed to those on placebo. And on the graph in the middle, what we see is that ability to reduce the steroid dose to 5 or less milligrams per day was only seen with Zeto, a third of the patients. And in fact, 3 patients were completely off steroids. When you look at the medium dose of steroids over time, this was also lower on the zetomipzomib treated patients compared to placebo. A phase 3 trial is in progress. And this was safe, well-tolerated. There were no SAEs related to the drug. But while we wait for these therapies to become available, let's turn our attention to 6-MP and mycophenolate, our old friends. And your own Komali published on this almost 10 years ago in a small subset of patients. Here is a much larger study for patients intolerant to azathioprine. We looked at the authors looked at treatment with 6-MP and with MMF. Even though tolerability was a little bit better with mycophenolate, both of them were reasonably well tolerated. And the rate of biochemical response was also similar, 60 to 66%. And this was sustained over a couple of years. So there's a resource for us. for patients intolerant to azathioprine. Finally, this is my last study to share with you. It's about inebilizumab in IgG4-related disease. This drug was FDA approved and EMA approved in April and May of 2025 for IgG4-related disease, which, as you know, is a multi-system disease, multi-organ disease. So the study was approved based on overall reduction in the flares for IgG4-related disease of 87%. In the liver meeting, Emma Culver presented data specifically for the flares, evaluating flares in pancreas involvement, biliary, and liver involvement. And it was very significant that we only had one patient with pancreatic disease who flared up on the inebilizumab group, and nobody with biliary or hepatic flares. So very significant, 97% reduction there. The only side effects were injection site reactions. So the drug was well tolerated. The take-home messages from this debrief then is that in PBC, the second-line therapies with PPAR agonists, and I know you don't have them available here, but you have fenofibrate, which is a PPAR agonist, leads to sustained improvement in biochemistries and symptoms, and it looks like it also improves clinical outcomes based on real-world data. Second-line therapies are underutilized in PBC. There is an opportunity for us. Elafibranor used in PSC seems promising. The phase 3 trial is starting now. Zetomipzomib is a promising new therapy for AIH. Phase 3 trial is also starting. And inebilizumab is safe and significantly reduces pancreatic and biliary flares in IgG4-related disease. So with that, I'm going to stop. Thank you for your attention.
Thank you, Dr. Levy, for this great talk. Any questions from audience?
I want to ask two short questions. Cynthia, thank you very much for your presentation. I mostly wonder your clinical practice management. First of all, about sclerosing cholangitis, you presented some drugs are really effective in biochemical response. But we know sclerosing cholangitis is not a biochemical disease. It's also associated with high risk of malignancies. And we know one study from Sweden showed our screening procedures are not really effective in diagnosing cholangiocellular carcinoma and others. And how do you manage patients with sclerosing cholangitis in your clinic? Because it's very, very rare in our country. Hopefully, it's a good thing for us because it's really difficult disease. And I wonder your opinion, first of all.
Thank you for this question. I agree. PSC can be very challenging to manage in many ways, and it is a pre-malignant disease. We have ursodiol available, and both in the United States and Europe, about 60% of patients with PSC end up receiving ursodiol, and I do see improvements in liver chemistries. So I individualize that because we have these clinical trials available, so if patients agree to participate and they qualify for a clinical trial, that's always my first choice for disease that we need to find therapy for. But if they don't qualify for the study, don't want to participate, then I may offer ursodiol for those patients. Okay. Now, as far as the screening, I know, so what he's referring to is an observational 5-year study, prospective study in Sweden with annual surveillance that wasn't able to really increase the detection of early cholangiocarcinoma in order to change outcomes for that population. It's true that that was shown in Sweden. I think most of us still do surveillance even though the data are limited. There's limited data from Mayo Clinic actually showing that you can decrease the rate of cancer-related events in patients who undergo surveillance. So there are more studies underway for us to really understand. But in the meantime, this is an opportunity for shared decision-making for sure. And I ask my patients, and most of them, I haven't encountered one who says, no, I don't want to do an MRI. They all feel like if there is something we can do to try and detect early, they're willing to do it. So I do MRIs once a year for my patients.
The second question, there are many response criteria in primary biliary cholangitis. They have good positive predictive values, but negative predictive values are not optimal. What is your treatment goal in PBC?
Yeah. So there is an almost, the statisticians will correct me, but almost linear relationship between the level of alkaline phosphatase and the hazard of transplant or death. So of course we wanted the lower the better, and if normal, even better. Now you take a 80-year-old woman with stage 1 PBC with an alkaline phosphatase of 200, do we need to add second line therapy? Probably not, right? Because you have to balance the cost, the risks of the drug. But you take a 40 or 50-year-old woman with a liver stiffness of 10 kilopascals, for sure, even if the alk phos is just above the upper limit of normal, I'm going to start second line because I want to see that very within normal range. So all these cutoffs that we use, Toronto, POISE, this is for research. In your clinical practice, like 1.5 to 2 times for most patients, but you have to individualize. If they have advanced fibrosis and they are young, then you want to be more aggressive and normalize their labs.
Thank you very much, Cynthia. We will get you back again. And now Professor İlker Turan will talk about non-invasive assessment of cirrhosis and portal hypertension. He is professor of medicine at University of Ege in İzmir. Yes, Professor İlker.
Dear chairs, dear colleagues, firstly, thank you very much for this kind invitation and opportunity to speak here. It is a great honor for me to be here. My topic is non-invasive assessment of cirrhosis and portal hypertension. All we know that the prognosis and management of chronic liver disease strongly depend on severity of progression of liver fibrosis. Non-invasive tests now play a key role not only in fibrosis staging, but also in diagnosing, stratifying cirrhosis, and in predicting complications. Of course, cost, availability, and context of use are important consideration when using this test. This is the nice illustration that shows natural progression from liver fibrosis to portal hypertension, eventually decompensated cirrhosis. Along this spectrum, the non-invasive test allow us to diagnose and stage fibrosis well before clinical decompensation. As shown here, commonly used non-invasive tests such as 5-4, ELF score, transient elastography, MR elastography provide cutoff values that correlate with the different stage of fibrosis. Today, liver biopsy, you know that the main reserved for select cases. In clinical practice, we can divide this test into blood-based tests such as APRI, 5-4, NAFLD fibrosis score, or more specialized tests, ELF, fibro test, fibrometer, and imaging-based tests such as transient elastography, MR elastography, or Shave-wave elastography. As we all know, simple scores rely on routinely available parameters and therefore well suited for the primary care, mainly to rule out advanced fibrosis. This table summarizes the main component of the blood-based biomarker algorithms used for fibrosis assessment. As you can see, these tests categorized in simple tests, mainly based on the indirect markers, and more complex tests that include indirect or direct markers reflecting circulating components of fibrogenesis and extracellular matrix remodeling. And this slide illustrates the advantage and limitation of this test. We know that 5-4, we see that it offers good accuracy, supported by a large body of evidence, is widely available, and comes very low cost. So the excellent first line tool to rule out advanced fibrosis. ELF provides higher diagnostic accuracy, but more expense, more limited availability. For imaging-based tests, transient elastography show good, excellent accuracy. Good to excellent accuracy is supported by more evidence base compared to MR elastography. MRE offers highest diagnostic accuracy, but it is used clearly limited by high cost and availability. And an important limitation of these blood-based tests affect their performance. Their performance are influenced by several factors, as summarized in this table. Variables such as age, platelet count, active inflammation, comorbid conditions may affect the accuracy of several commonly used scores. A key concept when using this test is the context of use, meaning the population and clinical setting where test is applied. What I mean, in low-risk populations, such as those in primary care, indirect markers like 5-4 show good sensitivity and are excellent negative predictive value of the more than 90%. However, as you can see, these curves, the specificity and positive predictive value of these markers remain modest, particularly disease prevalence is low. But in liver clinics, the pretest probability is advanced fibrosis is high, generally 20 to 30%. So the simple scores is no longer sufficient in this setting, so secondary tests such as transient elastography and ELF is recommended in this setting. So the practical question is which patients should be screened? Patients with risk factors for liver disease should be screened for the presence of advanced fibrosis. These include hepatic steatosis, high cardiometabolic burden, excess alcohol consumption, viral hepatitis, and persistent elevated liver test. So we know that the 5-4 and APRI is the two most common tests. 5-4 was originally developed for the HIV and HCV co-infection, but and then it has been extensively validated in muscle D and alcohol-related liver disease. On the other hand, APRI is commonly primarily used in viral hepatitis, and APRI greater than 0.5 can identify most adults who have chronic hepatitis B and significant fibrosis. In fact, 2024 WHO guidelines recommend the use of APRI to start antiviral therapy in patients with chronic hepatitis B, especially in low or middle income countries. And if the patients who cannot confidently classify it after initial testing move on to secondary tests, in this setting, transient elastography has been extensively validated for the assessment of common cause of liver diseases. In this setting, we know that less than 8 kilopascal can rule out the advanced fibrosis with high sensitivity, and more than 12 kilopascal consider the advanced fibrosis with high specificity. Regarding the MR elastography, it generally outperforms the early stage of the fibrosis, for example, F2 or greater, but had similar accuracy for advanced ruling in advanced fibrosis. Now look at the diagnostic performance, the non-invasive test. These are the meta-analyses conducted in selected disease populations. As you can see, for early stage of fibrosis, the diagnostic performance of these tests are modest. Only MRE in muscle D seems to provide highest diagnostic accuracy, but I said that its cost and availability limits its routine use. And what about advanced fibrosis? As you can see, FIB-DORT Triptort has good sensitivity at lower cutoffs, but specificity is limited. ELF shows acceptable performance. Elastography, either transient elastography or MR elastography, provides best overall accuracy. And when we move to cirrhosis, the picture changes clearly. Blood tests can still support the diagnosis, but imaging-based approaches provide greater diagnostic certainty at this stage. So this is a practical stepwise algorithm for identifying advanced fibrosis in patients with suspected chronic liver disease, recently published in New England Journal of Medicine. If we have a patient with clinical suspicion for chronic liver disease, the first test is 5.4. If test is less than 1.3, the patient is unlikely to have advanced fibrosis, so management can usually remain in primary care. If the score is 1.3 or more, the secondary testing is required for these patients. If the score is more than 2.65, this patient can be directly referred to GI or hepatology clinic. If the secondary testing shows us the advanced fibrosis is unlikely, such as transient, for example, elastography less than 8 kilopascal, ELF less than 9.8, MRE less than 3, this patient can be followed in primary care setting. If non-invasive tests such as advanced fibrosis based on the secondary testing thresholds, this patient should be referred to gastroenterology or hepatology clinic. If the results are discordant, we may need confirmatory tests. If results are discordant, we should consider repeat elastography or liver biopsy. If the when invasive test clearly shows the higher thresholds, advanced fibrosis becomes very likely. At this point, patients should be management in gastroenterology or hepatology clinic, and confirmatory testing is often not necessary. The focus shifts to clinical management and surveillance. And this is the recently published ASLD guideline algorithm for blood tests based non-invasive assessment of liver diseases. As you can see, the guideline proposes the different 5.4 thresholds for NAFLD or non-NAFLD populations. For non-NAFLD populations, threshold is higher, 3.25, whereas in NAFLD, the corresponding cutoff is 2.65. In addition, for patients with NAFLD, the algorithm recommends incorporating the NAFLD score to help rule in or rule out the advanced fibrosis. And this guideline also provides several key statements. The first statement is in adult patients with chronic hepatitis B and C undergoing fibrosis staging prior to start antiviral therapy, it recommends simple blood tests such as APRI or 5.4 as initial tests to detect significant or advanced fibrosis or cirrhosis. And the sequential combination therapy may perform better than single marker for patients with hepatitis C, untreated hepatitis C. For NAFLD patients, as well, simple blood non-invasive tests such as 5.4 and NAFLD fibrosis score is recommended to detect advanced fibrosis. Again, sequential combination of blood-based tests may be considered for diagnosis of advanced fibrosis. For other diseases such as alcohol-related disease or chronic cholestatic disease, the guidelines state that there is insufficient evidence to recommend using blood-based tests for staging fibrosis. And this is our study, recently published in the Hepatology Forum, which is the official journal of TUSL. We evaluated the 5.4, APRI, and FibroScan in biopsy-proven chronic liver disease, not only muscle D and viral hepatitis, but also autoimmune hepatitis and cholestatic diseases. As you can see, APRI seems to work in viral hepatitis. 5.4 is unreliable in autoimmune hepatitis and overlap syndromes. FibroScan demonstrate a consistent and strong correlation with histological fibrosis, almost all liver disease group. And given that muscle D has now become the most common liver disease we see in hepatology clinics, it makes sense to spend a bit more time talking about the muscle D. We know that the majority of the patients have no significant fibrosis. Their long-term liver-related risk complication is less than 1%. So the clinical challenge is to accurately identify 20 to 25% of patients with advanced fibrosis, as well as 1 to 3% of who already cirrhotic. ASLD guidelines recommend a three-stage approach, starting with the 5.4. When the 5.4 is higher than 1.3, the patient should go to secondary risk assessment with either transient elastography or ELF. If these tests indicate indeterminate or high risk based on the established thresholds, patients should be referred to gastroenterology or GI care for the further risk stratification. In this setting, additional tests such as MR elastography, liver biopsy, or ELF test can be performed. For example, ELF tests more than 11.3 suggestive of cirrhosis and predicts future liver-related events. I want to talk about some MR elastography. Really, I think the best validated test for staging patients with muscle D. Using a cutoff 3.5, achieve both high sensitivity and specificity with area under the curve of about 9.92. As this is the why MRI is positioned in current guidelines and confirmatory and tertiary tests, especially in patients with indeterminate or high-risk non-invasive test results. And this test is started to perform in our hospital. And this slide summarized a large meta-analysis by Salvarez et colleagues published in Journal of Hepatology in 2025. This study compared the several different elastography techniques, transient elastography, MR elastography, and shear wave elastography. And when we focus to advanced fibrosis, F3 or more, MR elastography showed the highest diagnostic accuracy. And the important observation is that the ultrasound-based techniques, transient elastography, shear wave elastography techniques, tend to overestimate the advanced fibrosis. And so we move on to clinically significant portal hypertension. This is the study developing and validating the point of care risk prediction models for liver-related events in patients with NAFLD and NASH. The models are based on the liver stiffness alone or anticipate NASH models for clinically significant portal hypertension. And the authors concluded that the anticipate NASH liver-related event models showed the best discriminative performance for identifying patients with clinically significant portal hypertension. So when we assess the non-invasive assessment of portal hypertension in compensated cirrhosis, it is important to recognize that the laboratory-based scores such as APR score, 4 score, or platelet count can help with cirrhosis, but not in the clinically significant portal hypertension. One major limitation is that this score are influenced by the platelet count, which can be affected by many non-portal hypertension-related factors such as infection, periosplenectomy, bone marrow suppression. As a result, their diagnostic accuracy for clinically significant portal hypertension is relatively low, with modest sensitivity and specificity. The role of the transient elastography in predicting clinically significant portal hypertension was already being explored more than 1 decade ago. This is one of the landmark study by Berzigotti et al. Published in 2013. This is important study because the hepatic venous pressure gradient used as reference standard, and this study demonstrated combining liver stiffness, spleen size, and platelet count allows robust non-invasive predictors of clinically significant portal hypertension. So we have known the liver stiffness predicts clinically significant portal hypertension. Boveno 7 show us how to use it in practice. Patient with liver stiffness measurement less than 15 kilopascal and platelet count more than 150,000 can be considered unlikely to have clinically significant portal hypertension. These patients have a low risk of decompensation and do not require further invasive assessment. On the end of the spectrum is liver stiffness measurement more than 25 kilopascal is highly suggestive of clinically significant portal hypertension regardless of platelet count. In these patients, cirrhosis-based management should be initiated. And the intermediate range between 15 and 25 represent a gray zone. Here, platelet count becomes important, and in selected cases, additional testing such as MR elastography may further refine risk assessment. And this is my last slide. More recently, we know that spleen stiffness is now gaining increasing attention in clinically significant portal hypertension risk stratification. This is a recent modeling study shows the spleen stiffness measurement can significantly improve the prediction of GSPH. When used alone, its accuracy is similar to liver stiffness, but its real value becomes evident when combined with the liver stiffness and platelet count. Importantly, adding spleen stiffness into the Boveno 7 framework reduces the gray zone for more than 20% to nearly 1/3 of patients. So the key message is that liver stiffness adds additional value to liver stiffness and platelets, helping us refine clinically significant portal hypertension risk stratification and reduce the diagnostic uncertainty. So finally, I would like to invite everyone to National Hepatology Congress will be held in May. Thank you very much for your attention.
Thank you, Dr. Turan. This is a good talk, and we have a lot of things to learn from you. Any other question? Any questions? Any comments about this topic?
I just wanted to know what guidelines say and what's your daily routine practice when you find, let's say, transient elastography score above 8 or maybe 12. How frequently do you repeat transient elastography? And what does guidelines say?
If the result is 8,
8 or 12, I mean,
12,
check it in every 6 months, once a year,
yeah,
2 years.
in our clinical
We know
practice,
what we're going to do about FIP4, but I mean, transient elastography.
transient is better. In our clinical practice, I repeated elastography yearly. Yeah. Is there any comment for the repeated elastography time frame?
I think everybody agree with you.
Thank you.
Thank you. The third topic is TLM debrief about portal hypertension. Please, Dr. Levy.
All right. I'm going to get tired of my voice today. All right, so now we're going to go over the debrief for portal hypertension. My disclosures have not changed. And I want to acknowledge Dr. Virginia Hernandez from the Barcelona clinic because she presented this at the liver meeting. Of course, I modified this and added my own slides, but it was great to have something to start with. And Adriele Martins is my clinical research fellow who helped me prepare the slides. So this is the outline. I'm going to start with some therapeutic trials. Then we'll discuss hepatic encephalopathy, hepatic recompensation, and a couple of abstracts on portal vein thrombosis. For the therapeutic trials, I'm going to address dapagliflozin, albumin, and certain antibiotics. All right, dapagliflozin. If you're not familiar, this is a sodium glucose cotransporter inhibitor, right, that is approved for the treatment of type 2 diabetes, heart failure, and chronic kidney disease. And it causes natriuresis and diuresis, and a mechanism that is different from the diuretics we're used to prescribing in patients with cirrhosis. It acts in the proximal renal tubules, right, different from the loop diuretics and the aldosterone inhibitors. So the hope in cirrhosis is that it can overcome those patients with refractory ascites, resistant to or intolerant to the diuretics that we're using. And it is safe in patients with up to moderate hepatic impairment. It can be used sometimes at half dose and without any significant side effects. So with that in mind, DAPA was evaluated in 2 different studies during this liver meeting. The first one was on patients with decompensated MASH cirrhosis with ascites and hyponatremia. And the goal was to see if hyponatremia could be reversed in these patients with moderate ascites. So they started with 144 patients and randomized them to standard of care treatment for hyponatremia versus the standard of care plus DAPA at doses of 5 to 10 milligrams. The primary endpoint was prevention of chronic kidney disease, and there were other secondary endpoints they looked at. The table shows the baseline characteristics. You see the median age there, 57. 3/4 of the patients were diabetic. The GFR was well preserved, even though these patients had diabetes, and the median MELD was 11. So the primary endpoint is shown on the bar graph with almost 70% reduction in the rate of development of CKD in patients treated with DAPA as opposed to placebo. Also, ascites resolution was improved with this treatment compared to the standard of care. Here are some of the other endpoints of CKD development. They also looked at AKI, so acute kidney injury incidence, and it was much lower in patients treated with DAPA as opposed to placebo. Diuretic discontinuation was more common in patients treated with dapagliflozin as opposed to placebo. And even those who continue to take furosemide or spironolactone, their doses, the mean doses at the end of the study, were much lower in the DAPA group compared to placebo. The most common adverse event was just urinary tract infections in 3 patients, leading to study discontinuation. But overall, a very positive study. Then, taking that into consideration, another study was using a combination of zibotentan and dapagliflozin in patients with cirrhosis and portal hypertension. So all patients at entry had HVPG done and it was greater than 10. Okay? They had cirrhosis that could be compensated or decompensated as long as the HVPG was greater than 10. 171 patients. Zibotentan is an endothelin receptor antagonist, and it's used in cardiac microangiopathic disease to decrease the vasoconstriction. So there is hope that it could improve portal hypertension. Its main side effect is fluid retention. So it was a good thought to combine that with DAPA to try to overcome that, given the natriuretic and diuretic effect of dapagliflozin. Baseline characteristics shown here, so a quarter of the patients were decompensated, 67% were on non-selective beta blockers. Most patients had alcohol use, alcohol-related liver disease or MAS-OD. And the mean HVPG was 16. As expected, with DAPA monotherapy in comparison to placebo, we saw increase in hematocrit and decrease in the fluid retention. However, unfortunately, the combination with increasing doses of zibotentan, and there were 3 different doses that were tested here, the combination of DAPA was not sufficient to overcome the fluid retention that we see with zibotentan. So it didn't work. We still had fluid retention, and there was no improvement in HVPG when corrected by placebo. Okay, so unfortunately, this was a negative study. Albumin, 3 studies that I want to share with you. The first one was looking at albumin in patients with cirrhosis and dilutional hyponatremia with the primary aim to correct the hyponatremia. Okay, so the study design were patients with decompensated cirrhosis with this dilutional hyponatremia. There were sodium was below 133. 52 patients randomized to standard of care treatment for hyponatremia with diuretic discontinuation and fluid restriction versus that plus albumin. And the way albumin was done was on day 1, 1 gram per kilo, and then for 10 days, 40 grams per day. All right? Here are the baseline characteristics. Alcohol-related liver disease was the most common etiology. Median MELD was 17, and median sodium was 128. And as you can see on the graph, the study met the primary endpoint with hyponatremia more often being corrected in patients on the albumin arm as opposed to standard of care alone. 3 times more likely to correct the hyponatremia. Also, they looked at 30-day mortality, and that was significantly improved in patients who received albumin as opposed to the standard of care alone. If you look at the table, we have 28-day mortality improved. The incidence of acute kidney injury was decreased in patients on albumin, and there were no more adverse events in this subgroup comparing to placebo. Second study was a sub-analysis of the Preciosa trial. The Preciosa trial had been previously published looking at long-term albumin over a year to see if it changed mortality, and it was a negative study. But here, the authors did a sub-analysis evaluating different subgroups of ascites according to the degree of ascites. So one group had grade 0 to 1, which was very mild. The other group had grade 2 to 3. And when you sub-stratify patients this way, we now see improvement in 1-year survival. For patients with moderate ascites, there was also less SBP and hepatorenal syndrome. So maybe identifying a subgroup of patients who could benefit from long-term albumin. And the third study looked at evaluating in a non-inferiority study whether a lower dose of albumin would be as good as the regular dose that we often use to prevent AKI in patients with cirrhosis, ascites, and SBP. Baseline, so the regular group, how do we do albumin? We give 1.5 grams per kilo on day 1, then we give 1 gram per kilo on day 3. So in this group with the lower dose, they utilized 1 gram on day 1 and 0.5 on day 3, but administered the same way. Baseline characteristics are shown here. A third of the patients had MASH, half more or less had alcohol-related liver disease. And you can see that for the primary endpoint, which was the incidence of AKI, there was no inferiority met. There was no different, the patients getting lower dose or regular dose of albumin no difference. However, when you look at AKI progression, so patients who already had some degree of AKI at entry, patients who received the low dose had lower rates of progression comparing to patients on conventional dose. Also, as far as side effects, so safety, the patients on conventional dose had more side effects, meaning they had more circulatory dysfunction. So perhaps utilizing low dose is as effective as and safer than if you utilize the conventional dose. Antibiotics, this was a study looking at patients with cirrhosis, with ascites, no prior SPP, and whether cotrimoxazole would impact mortality for these patients or not. So they randomized patients 1-to-1, placebo versus cotrimoxazole. The most common etiology was alcohol-related cirrhosis. Patients were treated for 18 months and followed for 48 months. The primary endpoint was overall survival, and it was no different between the arms. In fact, there was no change in the time to first episode of SPP, no change in admission rates, and even when they did a sub-analysis looking only at the high-risk patients, those with protein in the fluid below 1.5 grams, the use of antibiotics was not protective. So we really have no support for using primary prophylaxis even in the high-risk group. The other study on antibiotics evaluated the use of rifaximin. Well, we use rifaximin or Xifaxan in our patients with hepatic encephalopathy, and the question was, are we putting these patients at risk for infections with drug-resistant organisms? So Jaj Bajaj collected patients, almost 8,000 patients from an international cohort that included patients from low-income, medium-income, and high-income countries. Everybody's represented. So of the 7,800 patients, about 36% had an infection, and of these, 12% had infection with a drug-resistant organism. At first sight, on univariable analysis, use of rifaximin was associated with increased rates of carbapenem-resistant organisms. However, on multivariable analysis, this lost significance. What was truly related to the risk of having drug-resistant organism was high MELD. But it's an important diagnosis to make, of course, because infections with these drug-resistant organisms are associated with increased mortality. We know that. All right, moving on to hepatic encephalopathy. Actually, the papers that I'm going to review are looking at hepatic encephalopathy post-TIPS. This first one compared, so they used data from the TRINEX retrospective cohort, 10,000 patients or so who had received TIPS, and they used propensity matching to separate two groups according to age, younger than 65 or 65 and older, and to look at 30-day and 90-day outcomes. So they ended up with 3,685 pairs. And to summarize to you, unfortunately, yes, older patients are still associated, so doing TIPS in older patients is still associated with poorer outcomes at 30 and 90 days. The rates of bleeding or portal-vein thrombosis were similar. So it's not a contraindication to put a TIPS in an older patient, but we know that they are at higher risk for hepatic encephalopathy and other complications. In the other study from the Alta group, Yael Noble from Columbia put together this cohort with 700 patients who underwent TIPS. And they were followed for a median of 300 days. Then they looked at the rate of severe hepatic encephalopathy post-TIPS. And here, severe hepatic encephalopathy was defined as either 2 hospitalizations or more for hepatic encephalopathy, or the need for a TIPS revision because of hepatic encephalopathy. Here on univariable analysis, that was a surprise. The TIPS stent diameter was not associated with rate of hepatic encephalopathy, nor was the gradient and the percent reduction in the HVPG. On multivariable analysis, what we see is older patients were at higher risk for severe hepatic encephalopathy, those who had the TIPS placed for ascites, and those who were on renal replacement therapy at the time of TIPS. Those are the high-risk patients that we have to be more cognizant about. And use of lactulose and Xifaxan did not prevent really the severe hepatic encephalopathy in this study. Let's talk about hepatic recompensation, another topic that is very timely. We know the definition of hepatic recompensation by Bavino. You have to remove the underlying etiologies. In case of viral hepatitis, you treat the virus. And a year later, this patient should not have any ascites and not be on diuretics. They should not have reblood, and they should not have encephalopathy, not being on lactulose or Xifaxan. That's the definition. And improvement of the hepatic function. So in this study from the Bavino group, they looked at recompensation in patients with alcohol-related cirrhosis, Hep B and Hep C cirrhosis. The table shows the baseline characteristics, which are comparable, except the MELD was higher for patients with alcohol-related liver disease. So when you look at rates of recompensation, they at first sight look higher for patients with viral hepatitis compared to alcohol. However, when you adjust that for the MELD score at the time of recompensation, decompensation, and the age and sex of the patient, this loses significance. So it's the same rate of recompensation across the etiologies. And then looking at the bottom graph there, you see that regardless of the etiology, achieving recompensation is associated with improved survival. Another study looking at recompensation, this one is from the VA system in the United States, the Veterans Administration hospitals. So they had 20,000 patients here, and they evaluated more etiologies. They included MASLD in their group here. And in this graph, it looks like patients with viral hepatitis had higher rates of recompensation compared to MASLD and MAT-ALD, but keep in mind this is not adjusted for MELD, and we learned from the other poster that the MELD at presentation is associated with the rates of recompensation. In fact, when you look at the MELD trajectory on the right, you see that patients who recompensate are exactly the patients who have significantly improvement in the MELD sodium. This is a very neat study from China looking at recompensation in chronic hepatitis B patients, so very pertinent to the population here as well. The design is the following. They took patients with cirrhosis due to hepatitis B, naive to therapy. They separated these patients in two groups, compensated cirrhosis, decompensated cirrhosis. They treated their viral hepatitis, followed for a year, and then they compared outcomes of patients who were always compensated versus the patients who were decompensated but who recompensated. Okay, so they're looking at the impact of recompensation comparing to never having decompensated. Median follow-up, 45 months. On the far right graph, we see that by recompensating, we match the survival. So there's no more difference in survival between compensated and previously decompensated patients once they recompensate. But the rates of HCC and decompensation are still higher in those who recompensated comparing to those who never decompensated. I wish they had a curve just to show those who never recompensate, because it's even higher, obviously, right? The rates of HCC and remaining decompensated. If you never recompensate, they do poorly. If you recompensate, you're in the middle. And if you never decompensate, that's when you do your best. Then they looked at predictors. What is it at the time of recompensation that can tell me who is going to still be at risk and develop HCC and decompensate, and who's going to be okay? And what they found in this study was the platelet count. So at the time of recompensation, those with platelet count greater than 100 don't seem to have an increased risk for HCC or decompensation. Okay, portal vein thrombosis. I just have two abstracts for you. This one looked at patients hospitalized for cirrhosis with the goal that there were 7,000, almost 8,000 patients admitted, hospitalized for cirrhosis, no hepatocellular carcinoma, and the outcome was to look at 30-day outcomes. And they cross-sectionally looked who had new portal vein thrombosis at the time of admission, and that was roughly 10% of the cohort. Okay, roughly 10% of the patients had new PVT. And that was associated with poorer outcomes, both in hospital and out of the hospital. If you look at mortality, PVT is there, significantly increases the 30-day mortality. It also increases in hospital complications like AKI, and increases the rate of liver transplant afterwards. So this is not really new data, but it's large and corroborating what we knew and reminding us that we have treatment with anticoagulation that can perhaps decrease these risks. Finally, looking at outcomes and patency of TIPS for patients who had the TIPS placed for portal vein thrombosis from the ALTA study group in the United States. So here, they're comparing the outcomes of patients who had TIPS for portal vein thrombosis depending on whether they're cirrhotic or non-cirrhotic. And the population was about half and half. The enrollment, they were followed for at least 6 months. Looking at the graph, what we learn is, at the table, what we learn is, as expected, those non-cirrhotic patients with portal vein thrombosis, they're more likely to have a hypercoagulable state, right? Comparing to the cirrhotic patients, they are also more likely to require revisions. However, the patients who are cirrhotic tend to have more post-TIPS hepatic encephalopathy requiring hospitalization. Now, the rates of patency are the same. So it doesn't matter if you have cirrhosis or no cirrhosis, if your interventional radiologist is skilled enough and puts the TIPS in a patient with portal vein thrombosis, outcomes are similar in the two groups. So my take-home messages, dapagliflozin looks promising to improve ascites and ascites control without causing acute kidney injury. Short-term human albumin may reduce the rates of AKI and reduce mortality in patients with cirrhosis and hyponatremia. And long-term albumin may be helpful for patients with grade 2 to 3 ascites. Primary prophylaxis for SVP is not really confirmed to improve outcomes, so I don't think we can support that practice. TIPS in older individuals is still associated with increased short-term mortality and hepatic encephalopathy, hepatic decompensation. Patency rates in TIPS placed for cirrhotic and non-cirrhotic portal vein thrombosis are similar, and keep in mind, recompensation is worth it. It improves survival. I thank you for your attention.
Thank you, Dr. Levy. Because of time problem, we get only one question. Please.
Thank you very much for your contribution, Dr. Levy. My question is about dapagliflozin to decompensated patients. Concerned about hypoglycemia. Do they, because we know the decompensated cirrhotic patients are more prone to hypoglycemia. Do they report any hypoglycemia in those patients?
No, not really. The main adverse event was urinary tract infection. That's it. They didn't report significant hypoglycemia. Not in the abstract. Thank you.
Thank you very much.
Now we have a case presentation session. We will have two interesting cases. First will be presented by Dr. Bilger Çavuş. Please, Dr. Bilger Çavuş.
Firstly, I would like to thank the organizing committee for their kind invitation. In this session on chronic liver disease, I will present a case focusing on refractory ascites, hepatic dehydrothorax, and its management. I will begin by briefly outlining the patient's clinical presentation and medical history. The patient is a 72-year-old female. She presented with the chief complaints of shortness of breath and abdominal distension. Due to these symptoms, she was admitted to service. The patient has a 7-year history of liver cirrhosis secondary to MASH. Over the past 3 years, her disease course has been decompensated with the development of ascites. During the last year, she has required frequent therapeutic paracentesis. At the time of admission, she had tense ascites accompanied by dyspnea. Her past medical history includes hypertension and umbilical hernia, family history with hepatic steatosis in her father. She has no history of smoking or alcohol use. On physical examination, she had distended abdomen, umbilical hernia was present, and her cardiovascular examination was doesn't have any pathologic sign. Her saturation on room air was 95%. In laboratory examination, urine analysis was unremarkable with no evidence of proteinuria, hematuria, or infection. Despite diuretic therapy, spot urine analysis was markedly low with a sodium to potassium ratio below 1, consistent with ongoing sodium retention. In complete blood count, anemia and mild thrombocytopenia consisted with hypersplenism secondary to portal hypertension, relatively preserved coagulation parameters despite chronic liver disease. Mild renal dysfunction in the setting of advanced cirrhosis preserved hepatocellular function with mild cholestatic enzyme elevation was seen. Her MELT sodium score was 14 and Child-Turk score was 8B. Laboratory findings demonstrated hypoalbuminemia, hyponatremia, and mild renal dysfunction consistent with advanced chronic liver disease. Elevated inflammatory markers and pro-BNP suggested systemic inflammation and volume overload. Iron deficiency in this postmenopausal patient can be interpreted as secondary to chronic gastrointestinal blood loss with portal hypertensive gastropathy as a possible cause. She had tense ascites, so in acetic fluid analysis revealed serum acid albumin gradient of 2.3 grams per deciliter consisted with portal hypertension. Acetic fluid analysis showed a low neutrophil count with no evidence of spontaneous bacterial peritonitis. In patient with cirrhosis and ascites, systemic blood pressure is a critical determinant of survival. So also in our patient, she was using ACE inhibitors. We have to stop her medication, ramipril, because she has mean arterial pressure below 75. Chest radiography demonstrated a right-sided pleural effusion. A therapeutic thoracentesis was performed with removal of 1.2 liters of pleural fluid. Pleural fluid analysis demonstrated transauditive characteristics and histology was negative, supporting the diagnosis of hepatic hydrothorax. Similar to ascites management, sodium restriction diuretic therapy was performed for our patient, and strict dietary sodium restriction was implemented, and dietitian consultation was obtained to ensure adequate nutrition and prevent sarcopenia. Large volume and therapeutic paracentesis with intravenous albumin replacement was performed. However, despite these measures, the patient continued to require paracentesis every 2 days. Follow-up chest X-ray at day 15 demonstrated a clear reduction in pleural effusion. Although the patient's dyspnea improved and body weight decreased following optimization of diuretic therapy, urinary sodium extraction remained low, as seen in figure, with a persistent sodium to potassium ratio below 1. Further escalation was limited by rising creatinine levels, and despite reaching maximum tolerated doses, the patient was diagnosed with diuretic-resistant ascites. At this stage, despite the optimized medical therapy, the patient clearly met the criteria for refractory ascites. The key question then became, how should we manage refractory ascites? Patient informed about liver transplantation and tips. Based on the guideline stratification, the patient was classified as having an intermediate benefit risk profile, allowing consideration of both tips and liver transplantation. Although the patient is over 70 years old, preserved cardiac function, absence of prior encephalopathy, and moderate liver disease severity place her in the intermediate benefit risk category according to the EASL 2025. I won't tell this. As a part of the pre-TIPS cardiac evaluation, transthoracic echocardiography demonstrated preserved left ventricular systolic function with an ejection fraction of 63, mild diastolic dysfunction, and no significant valvular disease or pulmonary hypertension, indicating no cardiac contraindication to TIPS. And again, as part of the pre-TIPS examination, abdominal MR and contrast-enhanced CT angiography demonstrated cirrhotic liver morphology with marked ascites and splenomegaly consistent with portal hypertension. No focal hepatic lesions were identified, and portal as well as hepatic venous anatomy was suitable for TIPS placement. We performed gastroscopy also, and gastroscopy showed polypoid lesions in the antrum and fundus. Pathology revealed a hyperplastic polyp in the antrum and adenocarcinoma in the fundus. Grade 1-2 esophageal varices were identified without red sign. No pathologic findings were detected on colonoscopy. Endosonographic evaluation for this in the fundic polyp, it revealed muscularis propria invasion of the lesion. And also PET-CT findings demonstrate focal pathologic FDG uptake in this area. When we staged her gastric cancer, we were preparing her for TIPS, but we found a gastric cancer in our patient. In staging, the tumor was staged as clinical T2 and 0 M0, corresponding to stage 1B. And according to guidelines, curative surgical resection was offered, but our patient has a MELD score 14 and a child 8B. So we calculate surgical risk scores using the vocal pan cirrhosis surgical risk score. The estimated 30-day postoperative mortality is approximately 11%. According to MELD sodium score, MELD was 14, and estimated for 30-day postoperative mortality was 15%. So surgery was high risk for this patient, and then we go on our plan for TIPS. Does the presence of gastric cancer alter our decision to proceed with TIPS and in a patient with refractory ascites? Malignancy is not an absolute contraindication to TIPS. Contraindications are limited to intrahepatic tumors that preclude shunt creation. And in our multidisciplinary team consensus, TIPS considered appropriate for symptom control for our patient. And a covered vascular stent graft measuring 10 millimeters in diameter and 60 millimeters in length was successfully placed, resulting in a significant reduction in portal pressure from 40 to 16 millimeters of mercury. It was a significant reduction, although it was high portal pressure. From the third month after TIPS, the need for therapeutic paracentesis resolved, diuretic therapy and dietary sodium restriction were continued. Intermittent episodic hepatic encephalopathy developed after TIPS. The condition was successfully controlled with medical therapy, rifaximin and lactulose. After TIPS, following TIPS placement, the patient demonstrated significant biochemical improvement, particularly in renal function and nutritional parameters, accompanied by normalization of serum sodium levels. Importantly, MELD sodium score decreased from 14 to 8. The case was discussed again in our multidisciplinary team with the departments of surgery, oncology. Total gastrectomy was recommended. So, is TIPS only a bridge to liver transplantation? TIPS can be used for three main purposes: as a bridge to liver transplantation, as a definitive or palliative treatment, for symptom control in patients who are not transplant candidates. And for our patient, TIPS functioned not only as a bridge, but rather as a window of opportunity, enabling stabilization and reconstruction of oncologic surgical management within a multidisciplinary framework. Thank you.
Thank you for this good case. Any question or comments? Okay. Second case is presented by Mübin Özercan, Dr. Mübin Bey. Okay.
Hello, everyone, dear chairs, audience. I want to start my presentation with thank to organization committee, especially my encouraging mentor, Professor Idelman. And now, our case is 28 years old male, and he had nearly 20 years ago, he had splenomegaly and abdominal distension. And after 3 years, his abdominal distension worsened, and the ultrasound showed that his spleen was enlarged up to 16 centimeter, and in the MRI there was also splenomegaly and no flow in main right and left branch of the portal vein, and it was chronic thrombosis in the portal vein. And you can see the laboratory parameters here, and he had cytopenias, and the serological and biochemical parameters were normal. And in 2009, pediatric hematology made analysis for the thrombophilic condition, and nothing was found for him, and upper GI endoscopy showed that he had grade 2 and 3 esophageal varices and portal hypertensive gastropathy. And pediatric gastroenterology and surgery decided to do splenorenal shunt surgery for him. And after surgery, he had the varices grade 2 in upper GI follow-up analysis. Unfortunately, he had no follow-ups for nearly 6 years. And in September 2016, he had fatigue, dizziness, and nausea. And you can see the laboratory parameters. The liver enzymes get higher, and the serological parameters showed us he had acute hepatitis B with the HBV DNA more than 300,000 units. And spontaneously, his laboratory parameters improved, and he did not use any antiviral therapy for this statue. And portal Doppler ultrasound showed us he had portal flow rate nearly 17 centimeters per second, and no obstruction in the portal veins. And he had also splenomegaly as in previous ultrasounds, and of course he had periportal collateral veins. And in follow-up laboratory parameters, you can see the liver enzymes get improved, and he had chronic hepatitis B infection. Again, he had no follow-ups for nearly 8 years, and for this period, he had only 3 analyses for an eye problem, and they were not same in the 2017. And for a nose aesthetic surgery, he had preoperatively consulted for us for these laboratory parameters without any complaints. And you can see the laboratory parameters here. And we have a little bit transaminase levels. And bilirubin is a little bit high. FIB4 score is 2.7. And we know that he had chronic hepatitis B infection. And imaging showed us he had thin granularity in the liver parenchyma, splenomegaly, minimal sludge in the gallbladder, hepatic atrophy in the right lobe, splenomegaly, and collaterals. Now, what do you think about this patient? What should we do here? You can see the summary of him. What do you think? Do you have any opinion? Audience, cheers.
Are there any comments for the case?
In fact,
Yes.
yes, nearly 40.
Mm-hmm.
The question is this hepatic atrophy or distortion of the liver image is related to portal vein thrombosis effect or HPV-related chronic liver diseases. Is anyone concrete about that? Cynthia?
No, I think that's vascular. That's the portal vein thrombosis. I wouldn't expect just chronic Hep B to lead to hepatic atrophy. But I agree, I would treat this patient. I would have treated before for Hep B.
Thanks. And now we told him that about that, and we decided to follow him up for this, and we told him that you might have cirrhosis, and you should go on your follow-ups every 3 months, because we know that he don't come any follow-ups before. And we did the other chronic hepatitis etiological tests, for example, autoimmune hepatitis, Wilson hemochromatosis, and other viral panels. And he had no toxic consumption, alcohol or any medical usage. And we did his upper GI endoscopy, and he had grade 2 varices and portal hypertensive gastropathy also. And unfortunately, he did not come for any follow-ups. And in January 2026, nearly 1 month ago, he attended our clinic. With the abdominal pain, fever, and fatigue. And these are the laboratory parameters here. He had very high bilirubin levels. He had cholestatic and transaminase elevations. CRP was 120. And also we had positive HBV DNA levels also. And now, after this, we did MRCP because we had very high bilirubin levels, and MRCP reported that CBD and intrahepatic biliary system was normal, and there was minimal sludge in the gallbladder. What do you think about him? What should we do now? Is there any change?
We still didn't give HPV medication,
No.
right?
No.
We don't.
No, we didn't.
I mean, it seems to be cholangitis.
Yes,
I mean, maybe
thought like that.
the collateral related cholangitis, maybe the portal biliopathy, because the patient at my hospital with cholangitis symptoms, and also the bilirubin was high, and cholestatic enzyme was high.
Yes.
There is a sludge. There was a sludge in the gallbladder.
Yes.
Maybe this patient need the ERCP or.
What we did, in the MRCP, we assessed the MRCP image manually, and you can see here, these areas are irregular. So we thought about the irregularity, and we decided to do EUS for this patient. And you can see this is the CBD, this is the CBD, and around the CBD there are many venous collaterals. And in this short video of it, and we have some narrowing areas in the CBD. So we thought that he had portal hypertensive gastropathy, and because of this, we did ERCP for him. And you can see here, this is the mirror image of our ERCPs. This is the left lobe, and there is some irregularity here. And after dilation and the plastic stenting, you can see in the operation the relieving of the biliary system. And after 3 days, this ERCP, the bilirubin levels getting improved, and CRP also get improved. Do you have any comments?
I think MRI picture is not typical for the portal biliopathy because we didn't see any intrahepatic dilation or structure or cholangiocellular carcinoma seeing. I am surprised by the final diagnosis.
Yes,
Because that's not
the big
so
size
typical.
is getting bad. Thank you.
It may be. Would you consider full covered metal stent instead of plastic stent because it may lead shrinking of the intraductal varices?
In fact, we didn't think about it.
Because it's in the literature, it's recommended.
No, we put plastic stents.
Yeah.
So my question is this a compression of the collaterals to the bile duct, or was this a ischemic cholangiopathy due to the to the altered portal flow in the intrahepatic bile ducts? And the second question is, now we inserted the plastic stents, it's not suitable for metal stents. And did you plan a strategy to reduce these collaterals with portal vein intervention like TIPS or something else? Or are you planning to change these stents for the rest of the patient's life?
Firstly, I will start with the second question. Of course, we will change the plastic stent nearly 3 months after this procedure. And maybe we can use the metallic stent for it, but he had shunt, splenorenal shunt, when he was a child. And in fact, we don't plan anything for portal vein intervention. And first, what was first? It was compression, we think, because in US we saw that CBD was compressed by the vessels around it. We thought about that.
So it didn't look like a typical portal cholangiopathy look. So
Yes.
I was just wondering if there was something else going on. Thank you.
I mean, my question is audience, is anyone decide to put this patient on transplant list?
Of course, we can think, but just we make sure the portal vein, I mean that. Which part of is already occluded, I mean, so we perform the tomography and Doppler ultrasonography if it is it has a patency of portal vein, and then we can put on transplant list. But since you said that he is not compliant person, I mean, he
Yes,
so
unfortunately,
it's so
yes.
difficult to follow up, I think, this person.
Yes,
Thank you.
unfortunately.
Do you want to say anything? Okay.
Okay, we are closing the session. Thank you for all the audience and the speakers.